Hi, my name is Dr. Arman Kumar from the Brigham and Women's Hospital. I'm reporting on the Fit on the Go from the 66th American College of Cardiology Scientific Session here in Washington, D.C. It has been a very exciting morning. I'm accompanied here by our colleague, Professor Kaushik Ray from the Imperial College in London. He's a preventive cardiologist and has been extensive experience running trials focused on lipid lowering and prevention of atherosclerotic disease. Dr. Ray, can you first tell us what are you talking today from, what are the findings that you're discussing today from ODYSSEY?
So what we did in the ODYSSEY program is that we pulled all the phase 2 and phase 3 data. And so that gave us about 120 events. And we've previously shown last year in a circulation paper that when you look at on-treatment LDL levels, we don't find a J-curve. The benefit continues all the way down to LDL levels of 25 mg per deciliter. It's continuous, non-HDL exactly the same, ApoB exactly the same. But what we know is that at the moment, that the use of these monoclonal antibodies is being restricted quite considerably. So the one concept that we wanted to explore is that we've got a lot of people with ASCVD in the trial, high risk. Can you enrich those people further? So having characteristics like diabetes, for example, or a low EGFR less than 60, or having polyvascular disease, PVD with coronary disease, does that give you, when you achieve the same level of LDL reduction, a bigger absolute benefit? And that's exactly what we saw. So if you pull the groups together, ASCVD population, get benefits all the way down to 25, and if you look for every 39 mg per deciliter lowering, the point estimate of the hazard ratio is about 0.75, so about a 25% reduction per millimole of 39 mg. But the biggest absolute benefits were actually in the people that had the highest event rate. So in the people with, for example, EGFRs less than 70, you got almost a 4% absolute benefit, when you looked at getting people down to LDLs below 40. If you did the same thing with people with PVD, you got about 3%. If you did the same thing for people with multivessel disease, you got the same thing. So it would suggest that, for example, that for these people with multiple comorbidities, beyond statins, because the starting LDL is about 128, an add-on with ezetimibe may not be the most desirable. Going even further and deriving extra benefit would be the most desirable.
Now, ODYSSEY is using alirocumab, and there's an outcome trial that is ongoing. When do you think we'll have the results?
Well, we should have it roughly this time next year. We're about I'm the national lead for the UK. We will have it in about a year's time. It's a post-ACS patient population. There'll be a lot of events, but the most important thing, and I think that's relevant to what you saw today, is the average follow-up is much, much longer. The minimum follow-up in any patient is at least 2 years.
2 years.
So the average is probably going to be about 3.5 in that study, whereas it was about 2 in Fourier. And so, as we know with statins and as also with the Fourier data, the benefit that you get over time increases. So actually you want to expose people to a lower LDL for longer to see a larger relative risk reduction and smaller NNT and bigger absolute benefit.
I think that's a very important point. Now, we all were there at the late-breaking clinical trial session today where they talked about Fourier. I was wondering, will the trial change your practice?
Well, it reinforces what we want to try and use in clinical practice. The real challenge, I think, is the cost of the treatment at the moment. I think the most important thing is it says low LDL is safe. So this business about going down to a low LDL, people have disparaged the LDL hypothesis. You've now got 3 different drugs that lower LDL, that reduce, the only thing they have in common is LDL lowering. Not pleiotropic effects or anything else, LDL lowering. So you've seen that. We should stop talking about the LDL hypothesis. It's fact. You lower LDL, you will have fewer events. The other key thing about this is going to be the subgroups that will be looked at, because there'll be some where you get a bigger absolute benefit. And those are the ones that probably payers will take the foot off the pedal a little bit and say, okay, you got a big absolute benefit and a small NNT. That's, I think, going to be key.
Got it. Now, again, both in Europe and in the US, we are talking a lot about precision medicine. Now, do you think we could use omic data like pharmacogenomics or some biomarker data to decide which patient will benefit more from PCSK9?
Yeah, I don't think you will need to get that far. We can do something very simple, which is basically think about framing it. We use that for primary prevention. What we are going to have to do is develop risk tools. for people on statin therapy, it's the usual risk factors that determine your event rate. Having yet another expensive test, and unless you see an interaction, there's probably no real added benefit. Why don't we just quantify the usual factors better, but do it on treatment, develop new risk calculators, and that will actually improve your precision just doing that.
I think all very important points. So, Dr. Ray, very much appreciate your time, and thank you very much for enlightening us with all the work that you have done, and we look forward to findings from ODYSSEY outcome.